Hi, everyone. We'll go ahead and get started here, knowing a few more may join us during this introduction, but thank you for joining Virginia Clinicians for Climate Action in our 2020 webinar series, Health in Virginia's Changing Climate. Just a few logistical reminders. My name is John Bagwell with VCCA. All attendees are in listen-only mode for the duration of this webinar. We will be accepting questions. We'll have a 10 to 15 minutes at the very end reserved for questions and answers. Feel free to, at any point during the presentation, you should have a Q&A box on your menu, on your Zoom menu screen, where you can submit questions throughout the presentations, and we will collect those and answer them towards the end. The presentation will run about 40 minutes or so, and I'm going to turn it over now to Virginia Clinicians for Climate Action Chair, Dr. Samantha Adu, to introduce our presenter today.
Good afternoon, everyone. Thank you all for joining us today for the 7th webinar in Virginia Clinicians for Climate Action's series, Health in Virginia's Changing Climate. So as clinicians, we recognize the need to educate ourselves about how climate change is affecting the health of our patients. But we also recognize that healthcare is a major contributor to the climate change problem. The U.S. health sector produces about 8% of our nation's emissions. And Healthcare Without Harm has delineated the diverse sources of healthcare emissions, the #1 contributor of which is our very complex supply chain. But today we'll be hearing about a healthcare-related greenhouse gas that is less well recognized, but perhaps easier to address. Our speaker today is Dr. Matthew Meyer. Dr. Meyer was raised in Vermont and went to Middlebury College for his undergraduate degree in neuroscience. His interest in sustainability and conservation was fostered by time spent on his grandparents' farm in Wisconsin and working at Shelburne Farms, an environmental nonprofit focused on conservation and sustainability. He spent 2 years as a Peace Corps volunteer in Tanzania, where the concept of efficient resource utilization was understood. He returned to Vermont for a degree in medicine at the University of Vermont and subsequently trained in anesthesia and critical care medicine at Massachusetts General Hospital. He has a research interest in perioperative efficiency and sustainability and has published nearly 20 manuscripts, several book chapters, and 1 patent. He is currently a critical care anesthesiologist and assistant professor at the University of Virginia. It's my pleasure to welcome Dr. Myers.
Thank you very much for that wonderful introduction. And I'm really pleased to be here, and I appreciate that. I appreciate all the people that are out there listening to me. I hope we have a good talk, and I'm really interested in your thoughts. So please bring the questions and let's learn something. All right, so today we're going to be talking about high-value anesthesia care and the social cost of carbon. Just to begin with, I have no competing interests related to the medications in my talks. I have images of specific brands of anesthesia medications and technology. The images are publicly available. I am not advocating for or against a specific brand. Lastly, which might not be as relevant in this talk, but I always like to put it out there depending on what audience I'm having. I believe in science and the use of best available data to guide decision making. So what we're going to be talking about is high-value anesthesia care and the social cost of carbon. I'm going to go through a very brief anesthesia primer. I know I have at least one anesthesiologist in the audience. It won't be too bad. We're going to talk about classic value in healthcare. We're going to address the social cost of carbon. We're going to expound upon this idea that I've been playing around with, which is future value in healthcare. We're going to decide which inhalational anesthetic I should choose. And then we're going to talk about the real-world implications of the social cost of carbon. Right. So what is anesthesia? For this lecture, for this conversation, we only need a very superficial knowledge. If you want to get into the weeds, the works of Emory Brown and George Mashur and others are where you should go. For today, what I really want you to know is that anesthesia is balancing stimulation with sedation and analgesia. The stimulation, it probably goes without saying, it's the surgery. The sedation, the analgesia, comes in a variety of different forms most of which are encompassed on this picture. We have a couple needles for neuraxial spinals, epidurals that numb the nerves. We do regional blocks with needles. We sometimes use the IV intravenous medications such as propofol. And then a lot of times we use the anesthetic gases, which I think is what people most often attribute to anesthesia. And that's where we're going to focus our thoughts today. Desflurane, sevoflurane, and isoflurane. These are 3 volatile anesthetics, all of which can be used to get the job done, to put a patient to sleep, to keep them asleep, and to turn them off and wake the patient up afterwards. So this is an anesthesia machine up here on the left side of the screen. And this is basically almost all you need to do anesthesia during a case. You've got some monitors up here in the top left of the screen. These 2 little boxes down here are what hold the volatile anesthesia. And then there's a ventilator inside of there too that gets gases from the wall, sends them to the patient, and receives them again. In the top right corner are 2 close-up from a couple of volatile vaporizers. And then the bottom is the dial, which is the top of the anesthesia vaporizer generally, and allows you to dose how much anesthesia you want the patient to have. Getting a little bit more schematic and in detail is this picture. What's sitting in the middle is a vaporizer. In the top left-hand corner, I'm representing fresh gas flow, which is some jargon you're going to hear me mention. This is air, oxygen, or nitrous oxide that actually carries the volatile anesthetic. That goes through into the top, and then it goes into the vaporizer. In the vaporizer, you'll notice that there's a little joint. Some of the gases descend into the vaporizer, wind their way around, pick up some molecules of one of these volatile anesthetics, and then carry them out, join up with the rest of the gases, go down here to the patient, cross the blood-brain barrier, breathe in, anesthetize the brain, breathe out, and then a lot of those gases get vented. They go through the waste gas circuit, and then they get vented about 7 feet above the highest air intake on the top of the hospital and reach into the atmosphere. A small amount do actually end up getting recycled as well. Anesthesia jargon, just going to bring you guys inside the club for a little bit. So we're going to talk a lot about MAC, which is minimum alveolar concentration. A MAC of anesthesia is a term you hear in the operating room a lot, and honestly, MAC has about 3 different anesthesia-specific terminologies. The one we're talking about here is the average amount of anesthesia that a patient needs to stop responding to surgical stimuli. We're going to use that a little bit differently to compare different types and different costs of anesthesia, and we're going to talk about MAC hour, which is the average amount of anesthesia needed to keep patients from responding to surgical stimuli for an hour. And then I mentioned the idea of fresh gas flow again, but in order to deliver volatile anesthesia, all desflurane, isoflurane, sevoflurane, all patients need to also get fresh gas, which comes from the wall through the machine. And this can be air, oxygen, or nitrous oxide. And what's relevant is that the more fresh gas you have, the easier it is to dose the medication, but also the more medication you're going to waste. All right. So let's pretend that this patient is getting ready for surgery, and we need to choose which inhalational anesthesia we're going to give to the patient. There are 3 that are commonly used. Desflurane is blue, sevoflurane is yellow, and isoflurane is purple. Those are fairly standard colors. I assume that there's somewhere in the world that they're not. But the colors are really how people associate with them. And so I want you to just get familiar with them, because I'm going to use these colors throughout, and really these bottles throughout the presentation. So how do you make this choice? Color preference, we already sort of addressed. Financial cost, clinical outcomes, quality, classic value, social cost of carbon. How about future value? Something I'm going to define a little later on. Let's start with the financial cost, because this is really something that we're always hearing about, specifically in the OR, but really in healthcare all over the place. The cost of things, everything's expensive. We need to reduce cost. So from a cost perspective, this data is readily available publicly, and this jives with everything I've known from the couple institutions I've worked at. Desflurane is above and beyond more expensive than the other alternatives. So it's at least twice as expensive as sevoflurane per MAC hour. So this is a standardized anesthesia for an hour. And then isoflurane is $1. So isoflurane is $1 to provide anesthesia for an hour. Sevoflurane is $12, Desflurane is $26. If you use the cost paradigm, then it's sort of a no-brainer. If you're choosing on cost, you're choosing isoflurane. But cost is only part of this story. We also have to pay attention to what it does to the patient. From a quality perspective, how do these drugs actually affect the patient? Do they all get the same job done? I'll tell you from a very high level perspective, they all do essentially the same thing. But when you start to look at more granular nuances, they are a little different. There are 30 years of trials comparing desflurane, isoflurane, sevoflurane. I'm not in any way going to be complete, but I am going to provide you with a few representative examples of this, and you'll take my word on it, or we can talk later. So desflurane is faster than isoflurane. It comes off, the patient wakes up. Sevoflurane is faster coming off than isoflurane. But it's not, and I need to read this correctly because this is a little complicated, but less fast than desflurane is to isoflurane. So they're both sevoflurane and desflurane beat isoflurane in terms of the time that it takes for a patient to wake up. And this is really where the data exists. It's hospital efficiency. How quickly can you get a patient through? And that's a lot of times the decision point for volatile anesthetics. When we compare desflurane and sevoflurane 1-to-1, and we compare this in a patient population, bariatric surgery, patients with high BMIs, that should be favorable to desflurane, you find that patients open their eyes about 4 minutes faster. They have the breathing tube come out about 5 minutes faster, and they are a half point better on a 1 to 10 scale, 0 to 10 scale for PACU recovery. And this is in the best patient population to prove differences for desflurane. You're finding a 4-minute benefit to eyes opening, 5 minutes to getting the breathing tube out, and then just a slight hair difference in the recovery score. So without a doubt, these are statistically significant findings. But I do want to posit, are these actually clinically relevant? This is the best findings that they could find in a meta-analysis of randomized controlled trials, which by definition have very strict protocols and people following those protocols to the best of their ability. So in a controlled setting, you can maybe get out of the operating room 5 minutes earlier. In reality, who knows, but it's hard to imagine that 5 minutes is going to make that much of a difference in either a patient's clinical outcome or in a hospital's financial bottom line. So the way I'm going to summarize this is that desflurane and sevoflurane are essentially similar in terms of their quality. And then desflurane and sevoflurane are both a little better than isoflurane. And these are indicated by the maroon boxes with the approximately equal sign and the greater than sign. So if I'm going to choose based on quality, then I'm choosing either desflurane or sevoflurane. But quality and cost alone are not necessarily where we need to be. According to Goldman Sachs and pretty much anyone else you talk about, the future of healthcare is value. And value is a very important thought that we need to have because value is a very important thought we need to have because our resources are scarce, and we want to make sure that each marginal increase in cost that we spend is worth the outcome. If we're spending twice as much to get 2% better, is that really worthwhile? Value was really pushed to the forefront by Professor Michael Porter. He's at Harvard Business School and he's a healthcare economist now, but at the time he was just really interested in healthcare. And he wrote really the defining book, which is Redefining Healthcare. And if you're interested in value, then I totally recommend reading it. Despite the fact it's 15 years old, we haven't solved most of the problems that he wrote about, and his insight is still impressive. Regarding value, value is an efficiency ratio. So it's us looking at the quality and asking ourselves, how much money do we need to put in to get that quality? And then we look at the efficiency ratio. So it's quality over cost. So let's analyze our volatile anesthetics in that manner. So financial cost, again, for desflurane is $26. For sevoflurane, it's $12, and isoflurane, it's $1. If we accept the premise, and I think we should, that desflurane and sevoflurane are approximately equal, then desflurane drops out. And then you have to ask yourself, how much better in quality is sevoflurane than isoflurane? One way to look at it, and there are many, is if the quality is approximately $11 per hour greater, then sevoflurane should be your choice. If it's not, then isoflurane should be your choice when you're looking at this from a classic value perspective. And now I want to bring in a thought for all of you, which I doubt is conceptually new for you, but I think the terminology and the science behind it might be. I find the social cost of carbon to be fascinating, and I want to really take a moment to expound upon it with you all. So, starting with why it's relevant in a healthcare conversation. A few years ago, the World Health Organization made a fairly aggressive statement that climate change is the greatest threat to global public health in the 21st century. There's really no holds barred in that statement. So we're saying that in terms of all the public health crises that we're facing, climate change is the greatest. And so to that note, we need to start to pay attention to healthcare's impact and ability to improve the environment as well as climate change. One paper which came out a few years ago, which I think completely went under the radar and really was underappreciated in terms of what it's saying, was written by Professor Eckelman and Dr. Jody Sherman. Dr. Jody Sherman's an anesthesiologist who has done a lot of the fundamental research on desflurane as well as advocacy that I'm offering to you all today in volatile anesthetics in general. They looked at the environmental impact on the US healthcare system, the environmental impact of the US healthcare system on public health. So they looked at all the resources across the entire healthcare system, we're talking very broad swaths, and looked at how the consumption of resources as well as the creation of the waste byproducts and negative externalities that resulted from it harmed humans. And they quantified it in disability adjusted life years, DALYs, dailies. But the more telling statistic is once they start to convert those more economic terms into lives lost. And they estimate that between 40,000 and 100,000 lives are lost each year because of the waste products generated by the healthcare system. And I just want that to sink in just a little bit because that's an impressive statement. And that puts, even at the lower end of the mortality range, that would be the 8th leading cause of mortality in the United States, down at 40,000. So we need to figure out, as clinicians, we need to understand how we can reduce our environmental impact while continuing to provide, high value care to our patients. And so this is where I think the social cost of carbon comes into play. Before I go any further into here, I want to just offer a brief advertisement, I guess, or recommendation for this organization, which is Resources for the Future. If you are interested into the interaction of the economy and climate change, this institution is phenomenal and has a ton of resources. I am in no way on their staff, but I have definitely learned a lot from them. So the social cost of carbon, what is it? So it is a way to price the negative externalities that are associated with carbon emissions. So when I say negative externalities, I'm talking about climate change, pollution, change in the climate related to hurricanes, fire, pestilence, etc. This number, and this is so extraordinarily important in the world in which we are, in which decisions are made by algorithms and more so data-based, is that it's a quantifiable number that allows policymakers and decision makers like us to understand the economic impacts of our decisions in terms of increasing or decreasing emissions. And it's just a dollar number. So how do we get to the social cost of carbon? It is very complicated. It is not terribly complicated math, but it is a very complicated process to arrive at that math. But conceptually, the steps are pretty straightforward. First, you need to predict future emissions. The decision you're making, how much will it either increase or decrease emissions? Then you model the climate changes that are going to come from that. in terms of increased sea levels, changes in weather patterns, changes in rain, changes in fire. You assess the economic impact that these climatic changes will have on the economy in terms of reduced productivity of agricultural lands, in terms of migration, in terms of availability of water. You then convert whatever damages there are into present day value, and you sum them up. And the number that you result with is $1 per ton of CO2. And this can then be placed into any models, as we're going to show you. Just to give a little bit of orientation, because the concept of a ton of carbon dioxide is fairly abstract. The average car in the United States generates 4.6 tons of carbon dioxide each year. So think about a ton, and these are metric tons, of carbon dioxide as being about 3 months worth of your car and the pollution you create by just driving regularly. This metric ton has the impact of melting about 3 square meters. And I'm not saying cubic here, I'm saying 3 square meters of the Arctic ice. And so that means from the surface all the way down to the ocean, it's melting that 1 ton of carbon dioxide. So that's the real world impact. And then here's the number. So this was published a few years ago, 2018, and they estimated by country, and this is the international value. So their estimation is that it's $417 worth of injury to the world per ton of CO2 that's emitted. Now I'm bringing it back. So why are we talking about this in relation to volatile anesthetics? The reason why is volatile anesthetics are incredible greenhouse gases. They are on the lines of some of the worst ones that we have out there. And a lot of times they're not even accounted for because they're considered part of the healthcare system and medically necessary. So this is something that we all need to pay attention to. And it's also something that us as clinicians have almost complete control over. So the global warming of potential of inhaled anesthetics, and this was, and the reason I put this title up is Dr. Susan Ryan really got the ball rolling on this topic. And so a lot of this field, a lot of what I'm talking about is because of her work. I just love this graph. I think the research is phenomenal, and the researcher is even better. He and I have been communicating back and forth because I just think it's so cool. You don't need to pay too much attention to the nitty-gritty details, but each one of these boxes represents a volatile anesthetic that we use, and it's measurements, atmospheric measurements from throughout the world, the North Pacific, somewhere in Switzerland, Antarctica, places that have supposedly, theoretically, pristine atmospheres that you can sample from. And just to drive home a couple points, you'll see halothane, which is a drug we do not use much anymore. Some countries still use it, but it's very rarely used. The atmospheric levels are measured in parts per quadrillion, and they have been going down up until 2015. However, Desflurane, which is the newest of all of our volatile anesthetics, has been increasing. Sevoflurane has also, I guess sevoflurane is a little newer, basically wasn't around, and it's been increasing and seems to be normalizing. And then isoflurane seems to have stabilized out in the atmosphere in the past little bit. Again, that isoflurane being the bottom right-hand corner. Really don't need to know anything other than these drugs are actually individually identifiable in the atmosphere, and they're in the parts per trillion, the ones that are actively being used. Here's really where you need to pay attention. So GWP is a concept I want to explain. Might be familiar to some of you. It's global warming potential 20, which means over 20 years. So carbon dioxide is the standardization for this, and you'll notice that 1 ton of carbon dioxide is the equivalent of, 1 ton of sevoflurane emissions is 3 in terms of energy trapping potential. I just wanted to let that sink in. Perhaps 349 times more energy than that of carbon dioxide. And that only gets worse. Isoflurane is 1,401 times worse. And desflurane is 3,700 times worse. To put this into perspective, when people are talking about, in sort of the lay press are talking about issues surrounding carbon carbon dioxide and global warming, they talk about carbon dioxide is bad, but methane is worse. Methane's GWP 20, so this is the warming potential over 20 years, is 84 times that of carbon dioxide. So it's 84 times that of carbon dioxide, so that's very serious. But that is 1/50th of desflurane. So desflurane is 50 times worse than methane, which is 84 times worse than carbon dioxide. So the numbers that we're talking about with these drugs are just incredible. Here's a study that looked at the OR carbon footprint of 3 hospitals. You'll see Hospital A, Hospital B, Hospital C. They were from North America and the UK. And you'll see that anesthetic gases for hospitals A and B make up over 50% of the carbon footprint. Just let that sink in. The whole operating room, we're talking supply chain waste and energy of the operating rooms, and anesthetic gas is responsible for over 50%. And then Hospital C, it's 4%. That makes you want to drill down into the data, and what the data tells you is pretty telling. So I just want you to look at the red boxes. Desflurane, and then Hospital C, JRH, has 0 desflurane. Desflurane is a massive contributor to greenhouse gases. So getting back to the social cost of carbon, how do I apply that to volatile anesthetics? It's really not tremendously difficult as long as you know how much carbon dioxide is generated per MAC hour. And again, that's our unit that we're using to standardize between the different types of anesthesia. So fortunately, someone else did the calculations for me, but I have done them. Again, nothing that's not impossible with an Excel spreadsheet and some attention to detail. And then you take that, you divide it by 1,000 kilograms because the output is in kilograms, and you have to normalize to tons, and then you multiply it by the social cost of carbon, and that gets you your social cost of carbon per MAC hour of volatile anesthesia. And here you go. Desflurane costs you $77 worth of social cost per hour of usage. Sevoflurane is $3, and isoflurane is $6. If you're making your decision based upon the social cost of carbon, you're going to go with sevoflurane anytime. But it's just not that simple in the healthcare world. And this is where I want to introduce what I think is a very powerful concept, and one which I hope people will run with, and I'm going to run with it for a little while. And it's this idea of future value. So value is quality over cost. Typically, it's financial cost that is considered. But we need to think not just about the resources that we're using currently, but we need to think about the impact the resources we're using currently have upon the world in which we live in, because that is exquisitely important and has been shown to be important to the health of every individual in the world. So let's now put a modern twist on the value formula. All right, so by including the social cost of carbon, we are really incorporating the negative impact on the entire world of some of our behaviors. Stick with me, watch the numbers appear, and I think you'll get the gist of what I'm trying to show. So right off the bat, you have 3 different options. You have your desflurane, your sevoflurane, and your isoflurane. And what's being shown is the financial cost per MAC hour at 2 liters of fresh gas flow, for those of you keeping track at home and my anesthesiologists out there. So $26 for desflurane, $12 for sevoflurane, $1 for isoflurane for 1 hour of anesthesia. We need to consider the social cost of carbon alongside, which is again $77, it's in gray, for desflurane, $3 for sevoflurane, and $6 for isoflurane. We sum those up, which gives us $103 for desflurane, $15 for sevoflurane, and $7 for isoflurane. That's the cost of financial cost, as well as the impact of that choice on the greater environment and the people in the world. We then need to consider quality. So the quality, again, desflurane and sevoflurane are virtually the same, and sevoflurane seems to have a greater impact on, and sevoflurane and desflurane are both valued higher than isoflurane. If we normalize this, so we take away the dollar values and we just think about this in terms of ratios, desflurane costs about 14 times that of isoflurane, and sevoflurane costs about 2 times that as to isoflurane. If you're thinking about future value as defined as quality over financial cost plus social cost of carbon, you're going to be picking either isoflurane or sevoflurane. if the quality is approximately $1 greater per hour with sevoflurane, you're probably going to be picking sevoflurane more times than not. Here's a real world example that was published just last year, where they actually took the conceptualization of the social cost of carbon as well as the financial cost of their decisions and educated their clinicians on it, their anesthesiologists, their anesthetists, their residents. They taught them about the different various carbon footprints of the anesthetics, and they taught them about the costs. And from 2012 to 2015, they were able to reduce their CO2 footprint from 163 kilograms per case to 58 kilograms, so about a 2/3 reduction. This resulted in an actual financial savings, moving away from desflurane, using lower flows on their anesthesia machine, of $25,000. But what I want to really emphasize is that's also financial savings of $100,000 on the social cost of carbon. And now, they might not see that in their bottom line or in their checking account, but that is something that is worth a whole lot for a health system from a brand awareness perspective. If you can say that you're focused on saving the whole world with your behaviors and not just your bottom line, that really reflects well on the brand of a health system. So total savings per month, I calculate at about $125,000 a month, and that's $1.5 million a year in terms of savings from behaviors that are relatively simple and was really just an education intervention. Okay. So which inhalational anesthetic should I choose? If cost is just considered, it's isoflurane. If quality is just considered, it's desflurane or sevoflurane. If classic value is considered, it's sevoflurane if quality is about $11 an hour greater, or it's isoflurane. If social cost of carbon is just considered, it's sevoflurane. And if future value is considered, it's probably sevoflurane and it might be isoflurane. So I'm taking you back into history a little bit. This was an editorial written in 1991. Just look at the typesetting, I love it. This was the Welcome to the World desflurane editorial written by the editor-in-chief of anesthesiology, Lawrence Seidman. And I want to read it verbatim. I believe it is too soon to either embrace desflurane enthusiastically or to suggest that its differences are insufficient enough to preclude widespread use. After 30 years of research, trying to understand where it fits into our paradigm, after evaluating it from its financial cost, its quality, its value, the social cost of carbon, future value, I think it's fair to say that desflurane is not the choice of anesthetic. Isoflurane, sevoflurane, I leave it up to discretion, and I think you can make your well-intentioned minds can disagree. But in terms of desflurane, I think the onus is completely on the clinician to find the situations, they exist, rare as they may be, and when I say rare, I mean extraordinarily rare, rare as they may be, to defend the choice of using desflurane in their patient population from a value perspective. And I leave that full stop because I really do think it's time to move on from desflurane. 30 years later, I think we can finish Dr. Seidman's thought and say that it is not worth our time to bother with desflurane in the vast, vast, vast majority of cases. To this mean, the top paper I wrote, and it was a work of love and passion to put that out there. And so far, I haven't heard anything back from it. I'm sure I will from some people who love desflurane. And interestingly enough, at the same time, there was a team out in the UK that was having the exact same thought. And I don't claim a tremendous amount of original thought. I just claim putting a lot of ideas together in the same place. And I'm really pleased that this other team with Dr. Shelton and Dr. Sutton came up to the same conclusion, which is that it's time for desflurane to go. So I want people to take this concept of social cost of carbon and run with it. This can be used in any clinical decision making. All that's needed, and it's not a little all, but all that's needed is a life cycle analysis of a reference product that you're curious about and the alternative. Cradle to grave accounting of environmental impact. That's not easy, but there's people who do it, and there's already been a fair amount of that put out there. I think once you, so what you do is you take that cradle to the grave, you understand what the CO2 equivalent CO2 emissions are for your product and your substitute. You convert it to tons, you multiply it by the social cost of carbon, and you compare results. What I want people to do is to plug it into future value model and use this in a quantitative manner to advocate for improving choices in the healthcare setting. So this is the formula. Reach out to me if you want help sort of thinking through the options in your specific field. But this is the way that we get this sort of what's perceived to be a relatively touchy-feely concept of like doing well for the world and improving the environment into cold, hard numbers that can be crunched and people can actually look at and make comparisons with. So I advocate very, very strongly for people to think about how they can use this number in their management and decision-making processes. And now I want to show you that this is more than just me being, again, like sort of abstract. Who cares about the social cost of carbon? So everyone, for starters. So each ton of CO2 inflicts damage on people indiscriminately. It doesn't care really where you live. Everybody's going to be affected. Some countries are going to be affected more than others. This data comes from that Rick and al. Paper that I showed a little bit ago, where they found the total cost of carbon to be $417 on an international basis. They did break it down to some countries, and the US is $48 of damage per ton of global CO2 emissions. And that doesn't matter if it comes from Charlottesville, Virginia, or if it comes from anywhere else in the world. Each ton that's emitted into the atmosphere is $48 worth of damage to the US. India is going to take an outsized amount. $86 of damage happens to India, and that's a product of its geography and some other things that are unique to its country, setting, and population. Saudi Arabia is $47, Brazil 24, China 24. And each country has a number like that. I secondly want to follow with one of the major presidential candidates has in his platform that there will be an enforcement mechanism for CO2 emissions that includes milestone targets in 2025. I very strongly believe that when we talk about enforcement mechanism, we are talking about some sort of penalty, tax, levy, fine, however you want to mention it, that's related to the social cost of carbon. So this is for real. And for people who think that this is a one-sided issue, it's really not. So this is an article that, as I was writing this presentation, I thought was very relevant. So you look what you want about the politics. There was sort of a talking head storm about a statement Vice President Biden made about transitioning from fossil fuels, which I think even in the oil industry is sort of accepted. It's a matter of when, not necessarily if at this moment. And this is a New York Times article that was quoting some oil executives that say, energy executives have even endorsed levying a tax on emissions that are causing climate change, arguing that it would create incentives for carbon capture and storage, which would reduce emissions. This is no longer the toxic issue that it once was from a political standpoint. This is becoming more and more of a bipartisan issue. So I do believe that in the very near future, this is a fait accompli. So we need to make sure that we're thinking about this correctly. So here's another graphic that comes from the New York Times, and it shows the prices of carbon. So carbon taxes, carbon prices that people are paying to emit from different countries. And just to give you a sense of the range, it's between $5 and $30. And so that's, if you're going to emit a ton of carbon, you've got to pay this penalty. So I'm back to resources for the future. So I put into this model. So just want to orient you to this model. On the left-hand side, you've got billion metric tons of CO2 emissions. That's US total carbon dioxide emissions. You'll notice we're around 5 billion. And then this is looking over a 15-year horizon. So from 2020 to 2035 on the right side of the screen. If we continue to stay business as usual, we are going to slowly decrease our total CO2 emissions, but really negligibly. That's the prediction. However, if we are able to institute the same amount of money that we institute that California's instituted, which is about $15 per ton, and we give a 2% increase each year, which is online with inflation, so not really not really pushing the number, but keeping up with inflation, we'll be able to reduce our emissions in 15 years from 5 billion tons to 4 billion tons, so a 20% decrease. Stick with me here. So these are some back of the envelope calculations. Don't quote me on them, but check them out yourself. U.S. emits about 5 billion tons of carbon dioxide each year, and the GDP of the U.S. is estimated about $20 trillion this year. If you just do division, you will notice that we generate about $4,000 worth of GDP for each ton of CO2 that we emit. I think this is a fair standard to think about. If we charge only $15 per ton of CO2 emission, we're only charging 0.375% of GDP generated per ton of CO2, which to me seems like we're undercharging there. If we charge 1% of GDP generated per ton of CO2, and keep in mind there's some people who generate far less GDP per ton of CO2, and I'm thinking about, generating electricity with coal versus other people who generate, essentially an infinite amount of GDP because they don't generate any carbon. But keep in mind this range, if we charge just 1% of GDP generated per ton of CO2, that's $40. Let's plug that back into our model and see what happens. So if we look at total emissions in the US and we charge $40 per ton, and we do just a little bit better than keeping up with inflation, thinking that, this is American exceptionalism here. We can do better than anyone. So let's think about it. And we can achieve and push ourselves to reduce our emissions just a little bit. And over the course of the next 15-year horizon, we can actually have reduced our emissions by about 2/5, and get ourselves down to 3 billion tons of carbon emissions over the course of a year. This puts us on track to be carbon neutral by 2050, which is our goal. So I want to bring us back through the conversation that we've had, sort of a whirlwind of anesthesia and economics, which is, I hope, has been as fun for you as it is for me. First off, we need to get rid of Desflurane, or you need to have some sort of bar that people have to defend their choice to use it. Really, really defend it and think about it from a value perspective. There are unquestionably moments when the value is beneficial of Desflurane, but I challenge them to be moments and not part of the everyday anesthesia. I also want us to recognize healthcare in and of itself as our choices have impact on public health, referring back to the impacts on climate change that our choices have, and the World Health Organization calling climate change the #1 global health crisis of our generation and really our century. I want people to think about the social cost of carbon in healthcare. I want people to grab this concept of future value and use it to quantitatively defend clinical choices. Put it in there. I mean, it is something that people will be interested to sit and think on, and maybe if they don't buy it right away, maybe they'll get it in a little bit. But let's start talking up social cost of carbon as being a real negative towards choices that emit high levels of CO2 or CO2 equivalents. And on this, let's really think about the social cost of carbon. And I use recompense, but it's really, it's a tax, it's a levy when we're talking about CO2 emissions. When the federal government, if the federal government, and I think it's more a question of when the federal government starts thinking about having people pay for their emissions, let's make sure that the costs are actually appropriate. $15 is very little and won't necessarily help us arrive at the outcome that we want. $40 gets us in that ballpark, but $40 is per ton isn't even covering what's estimated as the United States' portion of each ton of the social cost of carbon for each ton emitted into the atmosphere, let alone the fact that we should probably, for every ton of carbon dioxide we are emitting as a country, should probably be covering the cost of the entire world, which would be 10% of GDP generated per ton of CO2 emissions. So let's just know those numbers and be comfortable talking about them, because that is actually what's going to really drive changes in behavior across the broader economy. So now bringing us back to one of the first slides. just want to make sure that I cover everything that I said I would and give you just a little summary. We did make an anesthesia primer. We talked about the balance of surgical stimulus and sedation analgesia. We talked about classic value in healthcare, which is quality over financial cost. And then we talked about the social cost of carbon, which is a quantitative representation of the negative externalities of CO2. It's a mouthful, but it's basically a way of putting into spreadsheets, databases, algorithms, a way to quantify the harm that CO2 emissions do to the global health. We presented the future value, which is this concept of incorporating social cost of carbon into your value-based decisions. We discussed that you should not use Desflurane unless there's absolutely a good reason and that's stated. And then we discussed the real-world implications of social cost of carbon, and these are in terms of carbon taxes and emissions reductions and understanding the implications of all of those. At this point, I really appreciate all of you being here with me. I hope you've learned something, and I'm very interested to take questions and comments. And I think there's a little bit more of an announcement from the VCCA.
Thank you so much, Matthew. And I know that Sam is going to jump on and share a couple of thoughts too. I found that very interesting and useful, even as a non-clinician was able to follow along most of it, I think. So thank you. During every webinar, we like to have just a couple of advocacy opportunity highlights, and then we're going to get to questions. I already see there were several very good ones submitted. But for advocacy this month, just wanted to highlight that yesterday VCCA released a new report analyzing ambient PM 2.5 concentrations in the state of Virginia and analyzing some potential policies that are going to be considered in next year's General Assembly related to transportation reform. It's a very interesting and informative report that we hope will add to the conversation about shifting away from the largest source of carbon emissions in our state in the transportation sector. So we hope you'll check that out. It's on a page with a lot of other resources as well, including some videos with Virginia-based health professionals discussing it. Also, just a few more days before the election, wanted to highlight our parent organizations, the Medical Society Consortium for Climate and Health. They have a host of resources related to candidate engagement, voting, open letters from health professionals trying to influence policy related to climate and health for the next administration, whoever that will be. And so I just wanted to highlight those two today for you. And then just a very quick reminder that this webinar is available for CME credits through Innova. You will all attendees will receive a follow-up email tomorrow with this link as well. But it's pretty simple to apply and get a certificate for attendance today. And with that, please keep the questions coming. And Sam, did you want to say anything before we turn it over to Matthew for answering the questions?
No, Matthew, I just want to thank you so much for that presentation. I found it fascinating and a really practical, straightforward way for physicians to conceptualize this issue and think about what the impact of their choices in medicine. So thank you very much. So yeah, let's go to these, please. Can you see the questions there, Matthew?
Sure, I do. So the first question is there any data on the carbon cost of the CO2 that is blown over cardiac surgery fields in most cardiac ORs in the USA? So I have to claim ignorance as to the CO2 that is blown over the cardiac OR fields. And that's as a cardiothoracic intensive care doctor. So I'm gonna have to learn something about this. So I don't know if there is, but I think it would be a great, I think it would be a great project. I mean, I know carbon dioxide is used clinically in the ORs for insufflation a lot of times for laparoscopic and or robotic cases. It's used sometimes to help with vascular cases when they're illuminating the vessels and trying to avoid contrast dye, but I don't know about it being blown over cardiac surgery fields. So I'd love more information about that and be interested in, in educating myself on that. So no, as far as I know, there isn't, but I think it would be a great area CO2 is blown to reduce air. Okay. Great. I appreciate the feedback. Okay, so are there any more effective or less environmentally damaging volatile anesthetics in the pipeline? Is there any incentives for research?
I think Matthew may have frozen. Oh, there you go. No?
Yeah, we may have lost Matthew in the hurricane that is currently over us here. Yes. Well, we will give Matthew just another second. Hopefully he can rejoin real quickly.
You could always type in the answer as well if you hear us.
Looks like he is trying to log back on right now. If folks can give us just a minute to get him reconnected.
All right, I think I'm back.
Here he is. All right.
Sorry. Thank you. I don't know what happened there. I guess I'll figure out how to hardwire next time. So I don't know where I got into that, but there's an anesthetic that's called Xenon that has been in the pipeline for some while. It's expensive. I don't actually know what its impact is. It is different. The other class of medications we talked about, isoflurane, desflurane, and sevoflurane, are hydrochlorofluorocarbons, CFCs. So those are all, again, tremendous greenhouse gases, bad for the ozone layer as well. But there's nothing that's coming up anytime soon. In my talk that I give to more anesthesia-minded people, I do mention that spinal neuraxial anesthesia, epidurals, regional anesthesia are probably the best way. And then using a total, if you need to do general anesthesia, total IV anesthetics are supposedly significantly better than even sevoflurane. So there are other options out there to reduce your impact. Volatile anesthetics across the board are not great, but they do come on the machine and they're so easy to use that it's going to be very difficult to have people switch over for, unless there's a great big push for probably financial reasons to doing mostly TIVA, regional, and neuraxial. Is there industry lobbying pressure that has perpetuated the use of desflurane? I wouldn't say industry lobbying or pressure. I think it's just standard marketing. It's about $1 billion industry, the sale of desflurane internationally. So there's a lot of money. And it was marketed as being a drug that was new and impressive and very fast on, very fast off. It has, we can get into the weeds in terms of some of its limitations, but it was initially tried in children and it caused significant laryngospasm, bronchospasm, respiratory issues in children, which is exactly what you do not want in children. And then they've just been trying to find niches for it. They've tried to prove that it's better for the elderly and reducing risks of cognitive decline after anesthesia. That doesn't prove to be true. There's actually evidence to the contrary. So it's at the very least equal to the others. So I don't think there's any real pressure and lobbying. I will tell you once I get the letters back from my paper that I just wrote, how invested people are or aren't in desflurane. And then this is a fantastic question. What about nitrous oxide? Am I wrong as an editor for the American Family Physician to discourage authors from mentioning this anesthetic unless they add a powerful greenhouse gas for OB patients when other alternatives are readily available? There are people who will say that nitrous oxide is probably a larger contributor. It is terrible. And the reason behind nitrous oxide being bad is that it exists in the atmosphere for 114 years. And then you also, in order to get any anesthetic effect of it, you need to have it at a very high percentage. So you can't actually do a general anesthetic with nitrous oxide. You can get like 70% of the way there. And so whereas the amount of, so just to give you relative numbers, for sevoflurane, I'm using a 2% sevoflurane mix, and then like the rest of it is either air or oxygen. So 98% is air oxygen. With nitrous, in order to get someone even sedate, I need to use like 50% or 70% of nitrous, and then 30% is air oxygen. So the number of molecules that you're releasing when you're using them, as well as the length of time that it exists in the atmosphere, it's terrible. And so I think the point about the OB patients is that's coming into vogue now, is using OB instead of neuraxial anesthesia. And that's great because it is one less hole, but it is definitely, especially for the people who are trying to keep their mind in terms of doing the most natural thing they can with childbirth, nitrous oxide is not particularly natural. And it's definitely a harmful intervention. I do not have numbers on how much we use, but it wouldn't be that difficult to at least mathematically model that. It's a great question. What do you think is the ideal way to regulate something like desflurane? For example, physician education, self-regulation, individual institutional policy, state or federal laws, changes in reimbursements. So, I mean, the easiest thing would be institutional policies. And I really emphasize the financial benefit of moving away from desflurane, because I think that's the biggest motivation for institutions to institute policy. I think there's also, again, I mentioned it once before, I think there's tremendous brand opportunity for health systems that want to drive hard at sustainability. This has been proven across all industries. I mean, the oil and gas industry is trying to declare themselves green industries currently, and yet it's difficult to prove to healthcare systems that it makes sense to be a sustainable institution. We are sort of behind the curve, and we don't really need to make this stuff up. We just need to crib from under other industries as to how to behave to really garner market share. That's my thought in terms of how you get the institutions on board. If the federal regulation came into play and basically said, if they capped emissions for health systems, I think desflurane would go away right away. Like there would just be no excuse. I think essentially volatile anesthetics would go away. I think there's probably an opportunity, and I do not know the logistics of this. I do not know the laws behind this, but it always rolls around in my mind in terms of there are people who actively capture chlorofluorocarbons in terms of coolants in refrigerators and air conditioners. And by capturing that, they can actually sell them on the market in California, and they get offset credits for it. So my guess is that there's probably some market inside of all of that to actually make money for the hospitals by reducing emissions simply by not using our volatile anesthetics, but I haven't dug into that. So I mean, my answer is all of the above. I think for right now, the best I'm left with is physician education and self-regulation. It does seem to work. But I will tell you from personal experience doing that at the University of Virginia, I got a lot of pushback, but we went from having a desflurane vaporizer in essentially every room to I think there's 5 deployed throughout the hospital right now. And I haven't looked at the data because it's only been about 6 months and half of that was COVID. So who knows what the numbers are going to look like from that. But I'm sure we've reduced it. But that took a fair amount of political capital, and there was a decent amount of grumbling.
Well, thank you again, Dr. Meyer, for an excellent lecture. I learned a lot, and I know the other members of the audience did. And we hope to be hearing from you again in the future.
Wonderful. Well, thank you very much. It was my pleasure to share time with you all. I hope you have a great afternoon.
Thank you, everyone. Bye-bye.
Thanks all.